So how we can make this bridging of the people's confidence and preference? Over to you.
Sir, as you said that in private and government medical colleges, the quality of services are not that good as to compare to the corporate hospitals. But I have different opinion in this related to our medical college attached hospital, because if I see quality wise, the quality of treatment is quite good at our hospital. So I think the quality standard which we are maintaining at our hospital, and in some of the hospitals in government medical hospitals in south also. So if people start maintaining that quality of standard, and as our hospital is also NEC digital accredited hospital, so if hospital take interested in maintaining that quality of standard, that definitely it can be possible to have the same quality of treatment in government and private medical hospitals which the other corporate hospitals are giving. So my opinion is to strengthen the quality standard itself in private medical colleges. I cannot advise the government medical college people to how they can improve, but definitely private medical colleges hospital can improve their quality of standard. And another thing which we can do is in private medical colleges we can have that premium class of services available to the patient on a paid basis. So people who want to pay and have that more better quality wise facilities available, they can have that facility in that premium building, like what the Karamsad Medical College nearby to us is doing. What they are giving that treatment in that particular wing with somewhat more cost. So this is my opinion, sir.
I fully agree with Dr. Komal that many private medical colleges, they have an excellent quality of medicine, but some may not have the government institutions, because the attitude and then the need for NABH accreditation may not be compulsory, may not be mandatory there. It is advisable. So I fully agree with many private institutions. Colleges are so good that they out perform any of the corporate hospitals. So that is maybe myth, but sometimes that is a perception. Now, the important thing also, maybe Dr. Komal, you can think about the private medical institutions which provide, or I would say medical institutions which provide. Government medical institution get a lot of grant from the government,
Yes.
and private institutions, they often say that the funding which they get from the resources they get from the fees and other things may not be adequate to upgrade the high tech infrastructure. So, should they, or do they deserve some government subsidy in case of a tax relaxation or maybe anything other, where they can also match the highest standard without straining too much on the loan and other things?
So, sir, as under Green Project, government is giving permission to run medical colleges, and under that they usually give a private institution a running civil hospital, and there they provide free of cost medicine also in that institution. So, such type of Green Project, if government is ready to give more such type of project to private medical colleges, then definitely there will be less burden on the college to run that hospital. So this type of different projects should be available from government side to private sector, so that more and more colleges are run by private institutions, and with a small amount of support from government will definitely improve the quality of care.
Dr. Upasana, can you comment on the quality of the care, which is it satisfactory today, or you think that the quality of medicine, quality of the equipment, quality of the devices which we give to our patients require some better or maybe upgradation? What do you think about it?
So I would like to thanks for giving me this opportunity. I would like to tell something which is related to our accreditation. So if somebody who is having accreditation, he has to maintain quality. So we are supposed to, encourage others also, that if we want to provide good quality care to our patients, we need to have some quality parameters. Otherwise, everybody is doing in their own manner, and lots of hospitals who are not having any accreditation, and even they are not aware about their equipments need to, time to time, see, they are not taking even CMC, AMC, not taking care of new, whatever is introduced in industry, they are not adopting that. So if you go to the big hospital, corporate hospitals, or any accredited hospital, you will find that quality of care is very good. Equipments are all up to date. But same time, India is a big country and we have actually large population. So we need more hospitals. So we are not discouraging anyone to run their setup, but we want that everybody has to have some quality, sense of quality, and they have to implement quality in their hospital. So especially if you see infection control, and calibration of the equipments, people are not doing. So we are supposed to, make create more awareness to everyone that they are supposed to maintain quality care in their hospital for their patients. Whosoever is coming to the hospital, we should not categorize the patients from their, economic background. Yeah, everybody need a good quality care, and they have to have it. Thank you, sir.
Yeah, that's a wonderful. I think you said very thing that whether it is paying capacity should not differentiate by the quality with the quality of that. Having said that, one part of the healthcare system is getting in the hospital, but a other component of the patient care is the patient who get treatment from OPD basis or maybe in the private practice. Do you think that in India, private practice or even the hospitals, they prescribe rationally, or the I'm just going to refer the antimicrobial resistance, which is now called as a almost silent pandemic. We used to call it silent pandemic, and I am WHO advisor for that. And now it is not silent; it is an evident pandemic, and that happens because of the irrational prescribing. A, and B, the prescription not being fully explained to the patient, and this lead to inadequate adherence or non-compliance of the medicine. So, what is your take, Dr. Arora? And then I will ask this question to all the three panelists here. I'm just figuring it out. In India, the doctor patient interface is in OPD. I'm not talking of a private sector, is considered to be very less, 2 minutes to 3 minutes. Because of this and many other reasons, patient is not explained the medication. And if the patient is not explained, he goes here and there. And then that leads to poor patient compliance, adherence, and drug interaction and ADR, all those things. Pharmacists in India, they just dispense but do not explain adequately. So how this also is a part of quality of healthcare system. So how you react to this? And I will just also say this is not universal. Some
Yeah.
hospitals I've seen, particularly in South, so meticulously the prescription is written digital. So meticulously is the dispensing is done. But that is very few cases. Over to all three comment. And in addition to, you can also comment on any other part.
Sure, sir. So, sir, I would like to say that it is not only problem with the hospital and pharmacist. The problem is this, that we are selling antibiotics without any prescription also. This is again a big cause of drug resistance. If I can see that if somebody is having cold or cough, he is going to take just AG every day without thinking about 4 days, 3 days, 5 days. There is no, my throat was not good, so I am taking AG. And no one is asking them why he is, taking antibiotic. Even sometimes I feel that we need to control this antibiotic use of in hospital, as well as create awareness. My hospital is a pharmacovigilance center of India, authorized center. So we are trying to, tell everyone and my doctors, and we are doing prescription audit, because there are every kind of doctors are available in every hospital, in every places, even private practices. There are few who are all the time writing just to save their timings, that their patient has to be okay. They are writing 2 3 antibiotics together. So that is why we are doing this prescription audit. So I think it should be on larger scale, not only limited to a private hospital or a single hospital or somebody who is doing best practices. It has to be mandatory, as lots of other things are mandatory in the healthcare. So, like you can see that when this NABH accreditation was linked with the CGHS panel and other panels, everybody started taking accreditation. Same manner, if we should start auditing to the hospital that how they are using antibiotics. Like NABH is coming to us, and they are our, actually they are looking our way of working. But if it will come through government, like I would like to give you example of Dr. Sanjeev Singh, who is working with Amrita. When he was in Kochi, he drive a very good drive for antibiotic policy in everywhere in Kerala. So I think that kind of zeal needs in every state. And like I am part of TB Mukt Bharat, so we are doing lots of things for TB. In same manner, if we will start talking about antibiotics and rational use of antibiotics, only then we are able to manage this problem, which you are actually saying that not silent, it's visible now. So it's a now vocal. Everybody knows that India's ICUs are not, patients are not responding because of drug resistance. So I want it, drive should be very on a very large scale, and all hospital and all healthcare person has to, play a role of with the this noble cause. Thank you, sir.
Dr. Arora, wonderful. And I must tell you that when I was in AIMS, we started pharmacovigilance centers with 10 centers, which increased to now 1,000 centers across the country now. And this is now being run by Indian Pharmacopoeia Commission, and I am their national scientific coordinator. The major problem with these centers is there are 1,000 centers, but nearly 400 centers are not reporting it. They have to be again and again send reminder, please report, please report. So we have opened the centers, but I'm not telling which centers are not reporting, but the reporting culture has to be increased. That is one. And I also tell you, there is a one very good startup which has started working engineers, and then they with IIT, a digital platform has been created with all prescription to be digitalized, and then which will also take note of what is the prescription pattern and prescription audit. So I think these type of things which you have said that you are already doing is something which is very good. Maybe I can ask others that explaining to patients their disease, how to take is really adequate, or we need to put some more attention to that. I will give you
Sir,
one, and Dr. Komal, I will just give you one example, because one of the reason of tuberculosis resistance was that patient will not explain properly that how long and how far the treatment is to be given, and therefore they left treatment initial stages after taking for 15 days or 1 month, because their hemoptysis or the fever improved, and they then thought कि अब हम क्या करें इसको देखे, and that was one of the also important reason for this. Over to you, Dr. Kamal. And maybe after this, Dr. Rajiv can comment on the same thing, and if anybody wants to comment on this.
So, sir, as Madam said, that more and more prescription audit should be done. In similar way, explaining the patient about the disease and how to take the medicine, I think there should be a compulsion of having a clinical pharmacist in any of the consultant who is practicing. मतलब कोई भी practice कर रहा है उनके clinic में clinical pharmacist होना चाहिए who can explain the dosage of the medicine, who can explain the what medicine is, how medicine is going to affect you, and for how long you have to take this. So as we are running PharmD courses also, so we have
Mhm.
that privilege to have that family interns and PharmD teachers available in all the areas of the hospital, who are guiding the patient and who are explaining the patient to how to take the medicine. And one more point I would like to add for this prescription resistant and irrational use of antibiotic is that till now many Ayurvedic practitioner and homeopathic practitioner are doing practice, and government is not is that strict in curtailing writing antibiotics by Ayurvedic practitioner and homeopathic practitioner, because they have taken their basic knowledge from some other medicine consultant, or they have worked for few months in some hospital. They do not know in detail about the antibiotics. So we come across many patients who are antibiotic resistant, and they are constantly taking treatment from this type of general practitioner. So rules has to be made strict that only a MBBS person or a MD person can do general practice also, because in India this is a big problem, I think, and this is going to affect very deeply to the antibiotic resistance. So this GP practice by non allopathic consultants should be curtailed. And another thing is clinical pharmacists should be made as a compulsion to have with a practitioner who is prescribing antibiotic. One day when I am talking with my friend who is practicing in UK, London, ही इज अ माइक्रोबायोलॉजिस्ट. सो ही टोल्ड कि कोमल तुझे पता है कि मैं राउंड लूं और मैं राउंड लेके यस ना करूं, तब तक द पर्सन कैन नॉट give the antibiotic. So this scenario is not there in our hospital. Even in my hospital, I tried ke microbiologist chahe they prescribe, and this means they audit the prescription and they give suggestion. But our consultants are not ready to accept this. So this culture has to be developed in each and every hospital, that once a microbiologist approved, then and then only that antibiotic goes to the patient. So this two three things has to be improved for preventing the antibiotic resistance.
I think that's really wonderful point, and we are spearheading a couple of workshops and seminars to creating awareness and having the responsible antibiotic prescription. There are several regulations for antibiotic prescription, particularly high-end antibiotics. And I will just tell you one thing: because antimicrobial resistance, we are at the verge of getting three more antibiotics, which will be effective against Pseudomonas resistance and against the highly resistant bacteria. But the issue which is being considered is that if those antibiotics are again introduced into the market, if you give new toy, wonderful toy to monkey, then what will he will do? He will just destroy it. Similarly, the apprehension is कि अगर ये नए एंटीबायोटिक्स इतने एक्सपेंसिव अगर हम यहाँ पे मार्केट में उतार दें और उसको जनरल प्रैक्टिशनर और कहीं जो इररिस्पॉन्सिबल प्रैक्टिशनर देना शुरू कर दें इधर उधर की जगह, then these antibiotics will also get destroyed in maybe much shorter time. So what you said is a very right thing. हमें अवेयरनेस एजुकेशन स्टीवर्डशिप को लगातार हमको करना ही है, अदरवाइज दिस विल बी वेरी डिफिकल्ट. सो कर्नल राजीव साहब, व्हाट यू थिंक इज दी, हम पेशेंट को कैसे, एक हम ये सोचते हैं कि हमने 70% तो हमने कवरेज कर दिया, 100% अगर हम कवरेज करें तब तो वो आगे की बात है. प्रिवेंशन इज इक्वली इंपॉर्टेंट. सो व्हाट रोल academic institution, private institution, and private practitioners can do for spreading the awareness of preventive measures to public? हम कोई इसको हम करते नहीं है, सिर्फ सोचते हैं सरकार ही करेगी. तो ये कैसे हम कर सकते हैं so that burden on hospital can be reduced? My second question, because the time is less, how innovations, particularly digitalization or maybe what we're talking about, artificial intelligence or innovations or technology, can play a role in improving the universal healthcare coverage? Over to you for all these two questions. Maybe you can respond one by one. Your wisdom,
I'll address prevention as the first issue that I need to address.
sir.
I think that's a very important aspect. Uh, we all know prevention is better than cure. We talk about it, but we do not actually practice it. I think every healthcare worker should take it upon himself as his bounden duty to create awareness while at the job and also while he's out of the job. By which I mean to say that all healthcare providers, all healthcare organizations, be it private, public, or whatever else, must take it upon themselves, must earmark time, resources, and manpower to go down to the people, create awarenesses on various aspects of medicine or cure and well-being, wellness as a whole. This needs to be done, and firstly, I think it is very important to catch people young. So maybe the right place to start is the schools and colleges. Advantage is that firstly you can catch them young. Secondly, these children will take it back home. So thereby educating their own parents, especially people who are not really educated. So awareness must be the order of the day. It must be a universal responsibility. Anyone to do with healthcare must get into the act of creating awareness. There must be adequate platforms created for that, and especially so in rural areas where people do not have that much of platforms coming up for picking up awareness. So awareness is the key, and awareness must be provided wherever there's an opportunity. And I don't see any reason why a healthcare organization should not have, in today's world with technology so well developed, have shorts, reels, videos, etc., to create awareness in the amongst the public. It can be available on any of the social media platforms. To give an example, in my hospital, we have already come out with about 500 odd videos, public awareness, create public awareness. So these are things which every hospital can do, and we can all have awareness camps created in various areas of our jurisdiction. So it does not have to be restricted to government or public or private. It can be all over, and anyone and everyone can do it. And it should also cover the mental health aspect. Generally, we have a concept that when we talk about wellness or healthcare, we only talk about physical care. No, even mental aspects. There are a lot of interconnected aspects. So therefore, there has to be an awareness on both mental as also physical well-being, and that has to start from the very beginning. Now, coming to the aspect of weaving technology into this, lots of benefits have. I mean, we have already seen the benefits of technology coming up. Firstly, the social media. We must make use of it. It is to our benefit. And fortunately, in our country, the Wi-Fi spread is so much, digitalization is so much. We can utilize this platform very, very effectively. Secondly, telemedicine and also home care. These are two aspects which have to be brought in a very big way. We can create this urban-rural divide to a great extent can be overcome by spreading telemedicine. Telemedicine, though we started this sometime about 14, 15 years back, it still has not really caught up. It did well during the COVID period. Once again, it's gone into decline. But to overcome the urban rural divide, this is the uh, way I can see an immediate effect coming up. So let's say hypothetically every hospital has at least 5 rural centers where telemedicine facilities available. I'm giving a hypothetical figure of 5. Let's look at the spread, let's look at the reach. It can create a fantastic reach, and treatment can be provided. Though that may not be the final solution, there still may be requirement for a patient to come up and see the doctor physically, but still a lot can be done through this telemedicine. Same is the case with home care. Home care also came as the next revolution in healthcare about 10, 15 years back, but it again saw a decline. I think when we talk about the number of beds and all that, we must build in this home care availability also into the whole thing. And there need not be any rural urban divide as far as telemedicine and home care is concerned. Also, we must utilize all applications. There are so many apps available today. There must be a direct connect between the physician and the patient using the app, physician and the hospital and the patients. So all round we have devices today which can help us immensely in spreading our reach. We must use it. And fortunately, India's got a very good digital connect today, which must be put to use for this purpose. These are my views on the subject. Thank
No,
you.
I fully agree with Dr. Colonel Rajiv because the technology will play a very important role and is playing a role. And we are increasingly using digital technology because India has the largest mobile coverage, and this can be what I feel. One thing, maybe Dr. Komal and Dr. Arora can comment on this. I have, after retirement from AIMS as a dean, I have participated as a voluntary couple of camps for education of the rural or deepest rural area on cervical cancer, cancer and women, because my wife is a radiotherapist, cancer specialist. That was the reason I connected with one NGO and I spent, at least I thought that one day in 15 days I will devote for that. I find that even after this social media is available, so many videos are available, they are so ignorant that personal connect which I see, हम सोचते हैं 100 लोगों को बुलाएंगे वहां पे से 200 लोग इकट्ठे हो जाते हैं. तो ये मुझे लगता है कि वन टू वन कैंप्स जो आपने कहा डॉक्टर कर्नल राजीव, आई थिंक दैट इज आल्सो वेरी इंपॉर्टेंट. वो हमको कुछ ज्यादा करने चाहिए, या मे बी डॉक्टर अरोरा एंड देन कोमल कैन कमेंट ऑन दिस, बिकॉज मुझे लगता है कि वहां से हम हॉस्पिटल लोड को कम करने में कुछ मदद कर सकते हैं, उनकी क्वेरी कुछ सॉल्व कर सकते हैं.
So, sir,
Komal, Aurora, and then
uh,
maybe Dr. Komal.
yeah.
Yes.
Komal,
So,
please.
sir, in our academic institutions, we have faculty of public health, we have faculty of social work also. We also have nursing college in our university. So, in Ayush institution, every week 2 to 3 camps are conducted in different villages in surrounding areas. So, our what we give a role to consultant is to examine the patient and give treatment, and our interns, they go to the villages, they explain the traditional way of preventive aspects of different diseases to the rural community. They also teach asa workers to how to take care of maternal and child health. So in spreading awareness and doing different vaccination drive, doing different health camps is a important part of our academic institution. So I feel very lucky being an academic institution managing trustee, because we have resources available with us. So we don't have to go ourselves in the rural area to spread this that awareness. We are doing on regular basis, and that training is part and parcel of their academics in our few of the institutions, like in, I said, public health, social work, nursing and Ayush institutions. And in medical college, we all know that as a NMC point of view, each and every students are also given a family. So regularly our medical students are also going in the village, and they are given 5 families, and they have to handhold that 5 families for entire their 4 to 5 years of their academic journey of MBBS. So we as an academic institution, we are lucky, and I think government should give more weightage on academic institution to spread this awareness about prevention and also treatment for the diseases also. And one more thing I would like to highlight is that, sir, we run a unique program named Think Tank series, like Shark Tank series. तो इसमें
Great.
क्या होता है कि मेडिकल स्टूडेंट्स, इंजीनियरिंग स्टूडेंट्स, बायोटेक्नोलॉजी स्टूडेंट्स, ऑल टुगेदर दे मीट ट्वाइस इन अ मंथ, and they discuss the different ground reality problems in that think tank series, and they find solution and they do innovations according to that. And we give in-house funding of up to 2.5 lakh for doing POC, proof of concept development. And in by doing so, we have developed two things for healthcare. One is total health care solution software, which is like telemedicine jo Rajiv sir ne bola, is that type of concept. So we are connecting the rural people through this THS for giving the more and more healthcare services. And another tool our student has innovated is very low cost ECG machine. So this is a 12 channel ECG machine, जो if we buy from the market, that cost around 1 lakh, but this machine which our student has invented, इट कॉस्ट अराउंड 30 to 35,000, और पेशेंट का ईसीजी होके उसका जो रिपोर्ट है वो कंसल्टेंट के मोबाइल की ऐप पे चला जाता है, एंड देन कंसल्टेंट रिपोर्टिंग करते हैं उसका, एंड दैट गोज टू द nursing staff and the ward staff. तो दिस टूल आर डायग्नोस बिकॉज ऑफ दिस थिंक टैंक सीरीज, क्योंकि उसमें क्या होता है कि बच्चे आते हैं, डिस्कशन करते हैं, सॉल्यूशन लाते हैं, एंड कंसल्टेंट आर आल्सो पार्ट ऑफ दैट थिंक टैंक सीरीज. तो कंसल्टेंट को, कोई लेप्रोस्कोपिक सर्जन को लगता है कि दिस इंस्ट्रूमेंट इज वेरी कॉस्टली, someone has to work upon this, and someone has to find out the solution for this, lower cost solution for this instrument. So this is the part of our routine academics, that people from the different discipline, they meet together and they find a solution for something which is very costly for healthcare system. So ECG machine which I am talking, sir, we have provided this 5 ECG machines to different PHCs in our surrounding area.
I think Dr. Komal ka kuch there was net problem. Is that with all? Yeah, Dr. Komal, you got freezed for a minute.
Okay. So, sir, another one thing which we are doing is we are everyone can hear me?
Yes.
Hello.
So another thing which we are doing is we have our flagship event called Vadodara Healthcare Innovation Festival, in which we invite people from different sector with the ideas for having that different innovation in healthcare, and we also invite investor in that. तो उसमें काफी 15-20 इन्वेस्टर आते हैं, एंड आइडियाज इज आल्सो इनवाइटेड, एंड टुडे आल्सो वी हैव आवर yearly flagship event Vadodara Startup Festival.
Wow.
So in our university we run a startup incubation center in which we support the startup idea for initial 1 to 2 year of time, and we also have a technology transfer center, and through this technology transfer center we have initiated this center since last 1 year, and in last 1 year we have transferred the technology, we have commercialized it. और हमारे 6 innovation, 3 from Ayurveda and 3 from biotechnology, we have commercialized this technology. So due to this we can able to find out a low cost solution for healthcare system. So this is
Very
the
good.
things which we are doing.
Dr. Komal, I think I very much appreciate the effort which your institution is doing. And I will just give you quick examples. When I was dean at AIMS, we started collaboration with IIT and AIMS, because unless you collaborate with that. And when I became president of
I'm
AIMS,
sorry to interrupt, sir.
yes,
Dear
I think
speaker, we are running short of time, yeah. So we need to wrap up
so
the session
finally I
in a
would
minute.
give an opportunity to Dr. Arora for quick comment, and then we will wind it up.
Yes, so for to reach rural people, I think we should hand holding with our PSC CSC. So pressure on quaternary and tertiary care should be less, and people can get their treatment or whatsoever. As you said, sir, their problems will be addressed there. So every private hospital, I have already made a pilot project and met with some government officials that all private hospitals and medical colleges has to have responsibility of nearby PHC and CSC, and it is going to help everybody, not only doctors, rather all the patients and nearby rural areas, they will be get benefits, and same time our workers also who are working in PSC CSC, they will also came to know about what is latest happening in healthcare. Thank you, sir. As Dr. Hema is quite parishan, sheesh.
Thank you. So I will just conclude this by thanking so wonderfully initially Dr. Gyani has given wonderful idea, then Colonel Rajivji, Parul, and Dr. Lal, and Dr. Aurora. So wonderful suggestions. So basically, if I say the 3-4 major points which have emerged is that the human resource is now we are becoming independent in human resource, but there is a gap between the some specialists, and that has to be taken care of in technology. And number two, quality of the particularly medicine, or drugs, or the is very critical. There should not be any compromise on the quality. It has to be done by DCGI or maybe regulator. Rural urban divide in the quality and the affordability and availability and accessibility is important, which has to be taken care of. The creating awareness in the public about the antimicrobial resistance or the therapeutic rationality and so on and so forth is important, which has to be done by each and every healthcare worker, including private and government medical colleges. And finally, the technology important for anything which is because of we have to leverage the availability of the digital strength and the technology support. So academic institution of medical sciences, academic institution of engineering sciences, technology, they should collaborate with it. Thank you very much. I think this was the discussion could have continued longer, but I am really my salute to all the experts. I wish I
Thank you
could
so
have
much.
met of the experts previously also, but now it's the beginning. Thank you, Prema.
Thank you all for being such an engaging audience. We hope this session has inspired new ideas and collaborations. Big thank you once again to our speakers and partners. Have a great evening ahead, sir.
Thank
Thank
you.
you.
Thank you
Next time
very
it
much,
should be
everyone.
2 hour session. It cannot complete in 1 hour, so it should be 2 hour session. Sure. Okay. Bye bye, everybody. Take care.